Good afternoon, judges. So my study is on refractive error change in over minus lens therapy for intermittent exotropia, a retrospective study. So intermittent exotropia is the most common form of divergent strabismus in childhood, and over minus lens therapy in intermittent exotropia is a known modality of treatment for reducing the angle of deviation. It stimulates the accommodative convergence and reduces the deviation in children under 6 years of age with minimal symptoms of asthenopia. Now, over minus lens in intermittent exotropia is used as a temporary treatment modality to improve the control before surgery and also as a long-term intervention with intention to wean patients out of the over minus treatment. Now, several authors have studied about the use of over minus lens therapy and its association with myopic shift after a period of time. This causes a concern among clinicians as to whether over minus lens can be given in intermittent exotropia. This retrospective study analyzes whether such a possibility is true in our clinical setting. So the objectives of the study is to evaluate the changes in refractive error in intermittent exotropia patients treated with over minus lens and to evaluate the effectiveness of over minus lens in intermittent exotropia as a primary modality of treatment or in conjunction with vision therapy in the form of convergence exercises in cases where it is feasible. It's a retrospective observational study done at Department of Pediatric Ophthalmology, Comtrist Eye Hospital. Duration was from January 2022 to June 2022. Patients aged 1 to 6 years of age with diagnosis of intermittent exotropia treated with over minus lens with at least 12 months of follow-up were taken in the study. No ocular systemic disease contributing to intermittent exotropia and refractive error, and the exclusion criteria was patients with follow-up less than 12 months. Coming to the results, 75 consecutive patients aged less than 6 years treated with over minus lens were analyzed. The mean age of patients was 3 plus or minus 1.5 years, and there was 61.33% females and 38.67 males. Coming to the descriptive statistics, the mean dose of over minus was minus 0.95 diopter plus or minus 0.23, and the mean duration was 19.36 plus or minus 9.44 months. And vision therapy in the form of convergence exercises were given in addition to over minus lens in 56% of patients. Comparison of spherical equivalent before and after glasses and hyperopes, there were 12 eyes. So before it was 0.43 plus or minus 0.34, and at 12 months it became 0.33 plus or minus 0.72. At 18 months it was 0 plus or minus 0.29, and 36 months it was minus 0.25. So the mean change in spherical equivalent was 0.1 plus or minus 0.38 decrease in 1 year, 0.04 in 18 months, and 0.68 decrease in 3 years. The p-value analyzed with Wilcoxon signed rank test was not statistically significant. Coming to the group of emmetropes, there were 86 eyes. So the mean spherical equivalent before glasses was 0. And then you can see that at 6 months it became minus 0.09. At 12 months it was minus 0.08 plus or minus 0.29. At 18 months it was minus 0.14 plus or minus 0.23. At 24 months it was 0. And at 36 months, it was minus 0.06 plus or minus 0.12. You can see that the mean spherical equivalent change from 0 to minus 0.08 diopters at 12 months and minus 0.14 at 18 months was statistically significant. Coming to the group of myopes, which was 52 eyes, the mean standard deviation before glasses was minus 0.47 plus or minus 0.25, and at 12 months it became minus 0.67 plus or minus 0.43. 24 months it was minus 0.63 plus or minus 0.58, and at 36 months it was minus 0.71 plus or minus 0.53. The mean change was 0.02 plus or minus 0.18 increase in 1 year. In 2 years, it was 0.04 plus or minus 0.18 increase, and in 3 years, it was 0.08 plus or minus 0.15. The p-value was not statistically significant. We also did a correlation analysis between the dose of over minus and spherical equivalent using the Spearman rank correlation coefficient. None of the tested correlations reached the level of statistical significance. Next is about the comparison of deviation before and after glasses. You can see that the mean deviation before glasses was 27.8 plus or minus 8.81 before, and after it has become 20.71 plus or minus 8.51. So that is for the near, and the p-value was again significant. For distance, the mean deviation 27.64 plus or minus 9.8 before glasses, and after it has become 20.45 plus or minus 9.48. Again, this was also significant. The Newcastle control score was also taken into account, and it was also analyzed, and the p-value was again significant. So both NCS and angle of deviation showed a statistically significant improvement after glasses were worn based on the paired t-test. Now surgery was done eventually only in 13.33% of the patients. Coming to discussion, major RCT done by the PEDIC group, which was published in JAMA, demonstrated that over minus lens, they used an over minus of more than minus 0.25 diopter overcorrection for a period of 12 months, was associated with greater myopic shift compared to the non-over minus group. Another retrospective study by Rustin et al. Studied that the over minus lens therapy in exotropes and concluded that they did not demonstrate more myopic progression than would be normally expected. And another retrospective study by Pola et al. They concluded that treatment of intermittent exotropia with overcorrecting minus lens did not induce refractive error changes, even considering age, treatment period, initial spherical equivalent, and overcorrection magnitude. So in our study, the highlight was to the need for a careful stratification by initial refractive error. So imetropes showed a statistically significant change in spherical equivalent at both 12 months and 18 months. And change in spherical equivalent in hyperopic and myopic groups was not statistically significant. While this contradicts some external findings showing higher risk for baseline myopes, it may be due to the smaller sample size in the follow-up cohorts. And so to conclude, over minus lens therapy achieved its primary goal of improving ocular alignment and control in patients with IXT, but this benefit was accompanied by statistically significant myopic shift in the emetropic cohort. So the clinical decision to use this therapy must therefore balance the high success rate in deviation control with the risk of inducing or progressing myopia. So limitation of the study was that it is a retrospective study. So there's a selection bias and small and decreasing sample size during follow-up, lack of proper control group for analyzing the refractive error changes. So a prospective study with a control group may be needed further for more validation of the findings. Thank you.
Just explain to us how this over minus therapy is helpful in controlling the intermittent exotropia. And second part is then what is your recommendation? On one hand, it is controlling intermittent exotropia, but on other hand, it is leading to progression of myopia. So how do you balance? Because we don't want progression of myopia also, and we want to control. Is there a midway?
So in IXT, what this O minus lens does, it stimulates the accommodative convergence. So the eyes are made straight. That is clear. So actually, this is a very good method in children in when we cannot use convergence exercise or vision therapy or anything to control this intermittent exotropia. So we actually give left and right over minus lens for children. But this concern has come up in based on this PEDIC study. So we decided what I recommend is actually we have to do a prospective study with a non-over minus group and an over minus group. Then only we can say what is actual result. Retrospective study won't be enough.
How much over minus? Suppose the child is having -3 in one eye and -5 in other eye. How much over minus will you give?
Actually, we give -1 in our institution. It's maximum what we give is -1.5. But the PEDIC study and all, they have given -2.5, more than -2.5 they have given. But in our institution is usually maximum is -1.5.
How long do you keep this over minus? How long does a child have to wear it before you say it's either failed or requires surgery?
No, we give it for first 1 month, then we again call back the children, and then we assess how she is doing, whether she's okay with the glasses, whether she is wearing, and whether the angle is controlled, how much control it has got. If there is no control and the child is above 4 years of age, then we will plan. If it is a constant exotropia, it has become a constant exotropia, then we will plan for a surgery. And if there is a suppression or there is a stereoacuity has come down, we will plan for a surgery.
Because you said only 13% eventually required surgery.
Yes.
So that means the remaining actually did well just with your O minus lens.
These intermittent exotropia is usually children who have a little bit of fusion.
Sure.
So with over minus also, over minus itself, they have good control. So surgery is not actually done. And these children are less than 6 years of age. So till 4 or 5 years, actually, we wait for surgery with convergence exercise and this over minus and all.
But your eventual increase in myopia is very minimal, isn't it? Once you
Yes.
take the children off
Yes,
the over
yes.
minus, so it's from what you're saying, it's a good thing then.
Yes,
Because
actually in hemetropic cohort, how I got a myopic shift was a bit of a surprise for me also, because we are giving left and right. So that was the point. So maybe a prospective study will give us more idea.
you also need to have a control group
Yeah,
with
yeah, yes,
just
ma'am.
no squints, because you want
Yes.
to know, because today new onset squint, I mean, myopia is so common in
Yes,
children
ma'am.
that you need a control group of
Yes.
no squint, no myopia to start with.
Yes.
Thank you.
Thank